Hi, I'm Dr. Dave. Morphine is a highly potent opiate analgesic drug, is the principal active agent in opium, and is considered to be the prototypical opioid. Like other opioids, e.g. oxycodone, hydromorphone, and diacetylmorphine, heroin, morphine acts directly on the central nervous system, CNS, to relieve pain. Morphine has a high potential for addiction. Tolerance in both physical and psychological dependence develop rapidly. In controlled studies comparing the physiological and subjective effects of injected heroin and morphine in individuals formerly addicted to opiates, subjects showed no preference for one drug over the other. Equipotent. Injected doses had comparable action courses, with no difference in subjects' self-rated feelings of euphoria, ambition, nervousness, relaxation, drowsiness, or sleepiness. Short-term addiction studies by the same researchers demonstrated that tolerance developed at a similar rate to both heroin and morphine. When compared to the opioids hydromorphone, fentanyl, oxycodone, and pepidin/meperidine, former addicts showed a strong preference for heroin and morphine, suggesting that heroin and morphine are particularly susceptible to abuse and addiction. Morphine and heroin were also much more likely to produce euphoria and other positive subjective effects when compared to these other opioids. Other studies such as the Rat Park experiments suggest that morphine is less physically addictive than others suggest, and most studies on morphine addiction merely show that severely distressed animals, like severely distressed people, will relieve their distress pharmacologically if they can. In these studies, rats with a morphine addiction overcome their addiction themselves when placed in decent living environments with enough space, good food, companionship, areas for exercise, areas for privacy. More recent research has shown that an enriched environment may decrease morphine addiction in mice. Morphine is a potentially highly addictive substance, as it can cause psychological dependence and physical dependence as well as tolerance, with an addiction potential identical to that of heroin. When used illicitly, a very serious narcotic habit can develop in a matter of weeks, whereas iatrogenic morphine addiction rates have, according to a number of studies, remained nearly constant at one case in 150 to 200 for at least 2 centuries. In the presence of pain and the other disorders for which morphine is indicated for use, a combination of psychological and physiological factors tend to prevent true addiction from developing, although physical dependence and tolerance will develop with protracted opioid therapy, and these two factors do not add up to addiction without psychological dependence, which manifests primarily as a morbid seek orientation for the drug. Endogenous opioids include endorphins, enkephalins, and dynorphins. Morphine appears to mimic endorphins. Endogenous endorphins are responsible for analgesia, reducing pain, causing sleepiness, and feelings of pleasure. They can be released in response to pain, strenuous exercise, orgasm, or excitement. Morphine is the prototype narcotic drug and is the standard against which all other opioids are tested. It interacts predominantly with the opioid receptor. These and H956 binding sites are discretely distributed in the human brain, with high densities in the posterior amygdala, hypothalamus, thalamus, nucleus caudatus, putamen, and certain cortical areas. They are also found on the terminal axons of primary effects within laminae and I, substantia gelatinosa of the spinal cord and in the spinal nucleus of the trigeminal nerve. Morphine is a phenanthrene opioid receptor agonist. Its main effect is binding to and activating the and-956-opioid receptors in the central nervous system. In clinical settings, morphine exerts its principal pharmacological effect on the central nervous system and gastrointestinal tract. Its primary actions of therapeutic value are analgesia and sedation. Activation of the and-956-opioid receptors is associated with analgesia, sedation, euphoria, physical dependence, and respiratory depression. Morphine is a rapid-acting narcotic, and it is known to bind very strongly to the and-956-opioid receptors, and for this reason, it often has a higher incidence of euphoria/dysphoria, respiratory depression, sedation, pruritus, tolerance, and physical and psychological dependence when compared to other opioids at analgesic doses. Morphine is also a and-954-opioid and and-948-opioid receptor agonist. And-954-opioid's action is associated with spinal analgesia, miosis, pinpoint pupils, and psychotomimetic effects. 8. Opioid is thought to play a role in analgesia. Although morphine does not bind to the and-963-opioid receptor, it has been shown that sigma agonists, such as plus benazocine, antagonize morphine analgesia, and sigma antagonists enhance morphine analgesia, suggesting some interaction between morphine and the and-963-opioid receptor. The effects of morphine can be countered with opioid antagonists such as naloxone and naltrexone. The development of tolerance to morphine may be inhibited by NMDA antagonists such as ketamine or dextromethorphan. The rotation of morphine with chemically dissimilar opioids in the long-term treatment of pain will slow down the growth of tolerance in the longer run, particularly agents known to have significantly incomplete cross-tolerance with morphine such as levorphanol, ketobemidone, pyritromine, and methadone and its derivatives. All of these drugs also have NMDA antagonist properties. It is believed that the strong opioid with the most incomplete cross-tolerance with morphine is either methadone or dextromeramide. Thank you for listening. Goodbye.